Chalo, let's begin. Nitish, how do you think this patient must have presented?
Seizures.
Yeah, and okay, describe quickly and diagnosis.
So well-defined cortical-based lesion in the right parietal lobe with multiple septations producing soap bubble appearance.
Very nice. Occipital lobe नहीं है या parietal lobe है?
Parietal lobe.
Yeah, parieto-occipital. I mean, you will need a tag to determine that actually. Yeah, ठीक है. And okay, so you have used just the right kind of descriptors. Okay, T2 hyperintense, well circumscribed, cortical base, multiple septa giving a bubbly kind of or soap bubble kind of an appearance. Patient presenting with seizure, most likely intractable seizures. Okay, intractable epilepsy. Okay, so that this most probable diagnosis would be a
DNET, desembryoplastic neuroepithelial.
very nice. So DNET is the most probable diagnosis. You also see something else too. This one looks like a this one is a, what do you see? I mean, just a quick description of whatever is seen.
T2 curvilinear, T2 hyperintense.
Hypointense septum. Septum hai. So then this can be a arachnoid cyst also. I mean, cyst within the ventricles, intraventricular arachnoid cyst. I mean, maybe because of some kind of an inflammation or whatever. Okay, there might have been a septum which developed within the ventricle. All these images I've taken from exactly 1 year back. Okay, we had discussed these cases exactly 1 year back, so 30th, 31st January last year. Okay, this is just a repetition of all that, but yeah, about a year back. Yeah, next. Pratibha?
Sir.
Yes, Nirish? Nirish?
DIVFs.
Come again?
Dural AVF.
What? I mean, there's nothing to suggest a dural AVF or anything. There's just a thickened vein and there is some medusa head kind of an appearance. This is a standard DVA, developmental venous anomaly. Yogesh, spot the abnormality and I'll give you the clinical clue once you have been able to pick up the abnormality.
So, medial temporal sclerosis.
Medial temporal sclerosis. Nilesh, do you agree?
Medial.
Whatever, medial temporal sclerosis. Yogesh is not completely wrong in at least being able to pick up the hyperintensity along the region of the hippocampi bilaterally. Somebody needs to switch his mic off. A lot of noise. Okay. But where is the dilatation of the temporal horns of the ventricles for you to say that there is sclerosis? You know, sclerosis gives rise to that abnormal hyperintensity as well as ex vasodilatation or dilatation, or because of the atrophy, there is minimal dilatation of that particular temporal horn. You don't see that here. So something else, Nidish? Yes, Pratibha?
So there's a T2 hyperintense lesion in the left temporal
We have killed that issue. There is T2 hyperintensity involving both the
expansion, gyral expansion is
with
not-
gyral expansion. Very nice. So I mean, with gyral expansion, we have T2 hyperintensity in the medial parts of the temporal lobes, bilaterally, the hippocampal region also. So
Yes.
like the uncus is bulky, uncus is bulky on this side and into the hippocampus. So what is it? I mean, when you see such a thing, you will think of what condition?
Encephalitis.
Encephalitis. So this particular regional involvement is called as
Hippocampal and
so there is a name, Nidish.
Limbic encephalitis.
So this is limbic
Limbic.
encephalitis. HSV
Correct.
encephalitis can also be present like this. It can sometimes be asymmetric also. Okay, but it should progress. Generally, what happens? The patient presents with fever and altered sensorium, and then when you do it first, you see this, and then maybe if temporarily followed up, it might spread along the limbic system also. Okay, but limbic encephalitis has other DDs as well, which you must look up, and because imaging in encephalitis might be a clinical scenario which you might get in the examination. Yes, Yogesh, that patient will also present. This patient will present with fever and altered sensorium and maybe seizure also. Yes, Yogesh, this patient should present with yes, Nidesh.
So
बोलो 15 सेकंड मिलेंगे
developmental
session में.
venous and DVA in the
No, there are no DVS.
Band heterotopia.
This one is a classic band heterotopia. Why heterotopia?
It's an abnormal gray matter is located in an abnormal location.
So heterotopia. Topy is related to geography. Okay, location, and hetero is different. Okay, so it is present at a different place from where it should be. So we can have band heterotopia or
So there can be periventricular heterotopias.
okay, very nice. No, that's about, see, it can be, so what happens is, where is this gray matter developing and where is it migrating to? These are migration disorders, right?
From
Yes. Where do they?
it is migrating outside, sir, from inside to outside.
Okay, so something called as the germinal matrix, remember? Okay.
Yes.
And the subependymal region, that is the region from where it is starting and migrating outwards to reach the cortical layer. Okay, it can get arrested anywhere along its path. So as you said, I mean, if it just escapes the ventricles, then it can be periventricular, then it can be like a band in the white matter, or even peripherally in the form of, I mean, it may not be a band, in which case it might be just a what heterotopia?
The subcortical.
No, the one is, see, that is about the location. Even bands can be present in the subcortical location, and this is like in the middle of the white matter, then it can be along the ventricles. But and this is an entire band-like thing. Can there be other kinds of morphological variants of heterotopias?
Nodular heterotopia.
Yes, nodular heterotopia. Okay, nodular heterotopia, band heterotopia, these are migration disorders. You must know about them. Okay, this patient will present with
Again, seizures.
again intractable epilepsy. Yeah, Yogesh.
Sir, artery of Percheron infarct.
Very nice. So this is a restriction of diffusion in the bilateral thalami, the region of the thalami bilaterally. So the thalami should be supplied by a PCA on either side. So something affecting a thrombus affecting or a embolus affecting both sides of the PCA would be very unusual. In which case we must always, whenever there is a suggestion of an abnormal blood supply, you must think of variants which exist there. So this one is an artery of Percheron infarct. There will be DDs. Okay. Yeah. Pratibha, what do you think happened here?
Sir, post of encephalomalacia and gliosis both.
Why? I mean, they uh, just to torture the patient, they did a craniectomy and then the patient underwent some gliosis underlying.
Mm, maybe it's a post-traumatic or due to some reason ICT was raised initially and then
You have everything to, put forward a hypothesis or, calculated guesses based on the evidence which is already available with you. A believable story. You might be right, but put your thoughts together.
sir, area of encephalomalacia noted in bilateral frontal lobes and the uh, left occipital lobe with extraocular dilatation and left fronto parietal craniectomy status. So, because I would think that has been some co-injury in the frontal lobes, co and
Okay.
counter co-injury.
Okay.
Injuries leading to encephalomalacia, and the craniectomy must have been decompressive craniectomy.
Very nice. So it must have been decompressive, I mean, massive. See, these areas are what you remember the initial algorithm in which you first spot an abnormal black area. Okay, the next question you ask yourself is whether there is a negative mass effect or a positive mass effect. Okay, generally, if it goes on to the positive mass effect, then you ask yourself if this area of hypodensity corresponds to areas which are mostly prone to injuries. So the basifrontal regions, the temporal poles anteriorly and the occipital poles are all prone to injuries, coup contre coup injuries. Huh? So yes, this might have been a coup injury, a contre coup injury with maybe a large EDH or maybe a large hematoma which was associated with this, okay, which had to be evacuated and a decompressive FTP needed to be done. The other thing that could have been, I mean, although there is a large part which is missing here, and because the PCA territory is also in some cases you might have a large malignant MCA territory, in fact, which in fact, which might also be needed to be decompressed, and the appearances might be similar. Okay, but this is absolutely good guesswork means calculated, measured interpretation of whatever the findings are. Good. Yes, Nidish. Yogesh?
Listen carefully.
Listen carefully. What is listen?
Smooth.
Smooth. So there are no gyrations, no pulsations. It's a listen carefully. Yogesh?
Sir, uh, meningioma extending in both bilaterally.
So bilateral falcine meningiomas. You can tell that from very avidly enhancing, well circumscribed parafalcine location lesions which have extraaxial lesions. Such avid enhancement, attachment to the fox. Okay, plus the other day in the clinical meeting, remember what they began the clinical meeting with, that meningioma is the something of neurosurgeons. What is it? क्या था, कुछ तो भी तो था. Okay, so that's their bread and butter kind of. That is the soul of neurosurgery. Okay, because it's such a common tumor and such a ubiquitous tumor. I mean, everywhere it can be parafalcine, it can be cortical. कभी सेलार हो जा रहा है, कभी सीपी एंगल में निकल आ रहा है, कभी optic nerve में, etc. So neurosurgeon needs to know the meningioma inside out, and consequentially you must do. Yes, प्रतिभा? प्रांजल नहीं आया क्या?
Sir.
आजकल प्रांजल मिस होता है, क्या चक्कर क्या है? Okay, yeah, प्रतिभा.
Sir, a T2 hypointense mass lesion in the right temporal lobe with surrounding vasogenic edema, infiltrative kind of.
Yes, Nidish, you agree? Yes, possible.
With a
I'm just
positive
asking
mass
Nidish.
effect.
With a positive mass effect. Okay, so there is a lesion which is based in the white matter. Majority of it is in the white matter with extension into the cortices also. So there is T2 hyperintense, which is finger-like extension suggestive of vasogenic edema. There seems to be a central part which is showing a variegated signal intensity appearing T2 hypointense also. So what is happening here, Pratibha? Yes, Nidish, what is happening here?
Bleed, sir.
The bleed.
Variegated
So there is a
So this
bleed
in
there.
the
So it's either a bleed with a mass, okay, or bleed within a mass, or it's just a bleed. So Nidish? Give me a quick 3 or 4 DDs of this appearance. जैसे मतलब एक घूमते घूमते जा रहे हो, इन स्क्रीन पे ये दिख रहा है, तो there should be thoughts crossing your head. Each one of these images, when you are like a single look at any of these images must. अरे कहाँ चला गया ये? बोल.
Cavernous.
इतना बड़ा कैवर्नोमा ब्लीड करके आजू बाजू में इतना इडीमा. I mean, that should be the last thing to say. ना तूने कितनी बार कैवर्नोमा ब्लीड देखी है? I mean, at least heuristically try to think, ना.
Sir, glioblastoma
Could be
metastatic also.
Yeah, metastasis. You should think of a metastatic. A hemorrhagic metastasis is so much common. Then yes, a GBM, so that is a glioblastoma multiforme, or a high-grade astrocytoma may have bleed within it. Okay. Anything else? So that
CVT.
is the. Sorry.
CVT, sir.
CVT, excellent, very nice. I was looking for that. That this might be a cortical bleed. Okay, if the patient is hypertensive, then you must entertain that too. But with the kind of vasogenic edema and this thing, always, and a cortical based bleed, you must always think of a CVT and evaluate accordingly. Okay, had there been multi-compartmental things, think of coagulopathy, think of drug. vasculitis, etc. But these 4 or 5 things must cross your mind, and why not a trauma also. However, this area is not an area which is usually affected by trauma unless it has been a direct trauma. Yes, Yogesh?
So pilocytic astrocytoma.
Nidesh?
Cerebral abscess is secondary to frontal sinusitis.
Okay, so you can see enhancement in the right frontal sinus. That is one of the commonest causes how a cerebral abscess develops. That is, spread of infection from the paranasal sinuses goes into the extradural, dural, subdural, intraparenchymal, intraventricular. Okay, I mean, I'm going from outside to inside and further in. So this is a cerebral abscess secondary to right frontal sinusitis. Good. Yes, out of the 3 of you, anyone? What structure is being pointed out by these arrows, Pratibha?
Mammillary bodies.
So you have
Hyperintensities, the flare hyperintensities in the
पर ये तो white matter white नहीं है.
so
White
T1 hyperintensities
T1 hyperintensities in the mammillary bodies.
bodies.
In a spotter situation, you will only give one diagnosis. Yes, Nidesh? Yes, Yogesh?
So Wernicke's dorsiplex.
Wernicke's encephalopathy, huh? Okay, very nice. Yes, Nidesh? Yogesh?
Hemangiopericytoma.
Okay, that should be a good differential diagnosis. However, we just discussed that anything which is peripherally located shows some variegation of signal intensity within this, maybe some calcification, some bleeds. Okay, and avidly, not avidly enhancing. This is not a post contrast, but yeah, this one in terms of hemangiopericytoma will be so much less common than a meningioma. Plus, there is no real destruction of tissues around it. The bones seem to be okay, and it doesn't even. It seems to be respecting the dural margins also very nicely. So meningioma or DD as a hemangiopericytoma. Otherwise, the dural method भी बोल सकते हैं. Yes, Yogesh. So did everyone get that? I mean, it's an extraaxial lesion, okay, which peripherally it's a cortical, it's broad based towards the cortex, and there is some variegation of signal intensity, some calcification, evidence of calcification by hypointensity on, could be blood also, but in all probabilities this would turn out to be calcification. Variegation थोड़ा रहता है. Yes, Yogesh, quick.
Sir, hypertensive microangiopathy is where the bleed
That's one
in.
possibility. Anything else?
So amyloid angiopathy.
Very nice. Anything else? Multiple cavernous angiomas. Anything else? Multiple calcified tuberculomas. Granulomas. That is NCC or tuberculomas. Then, anything else?
DAI.
DAI. Excellent. Very nice. DAI. Anything else? Multiple hemorrhagic metastasis. Okay.
Yes.
So all these are appearances. I mean, if you are shown this, you should be able to rattle them out. So this is an SWI image showing blooming on the thing. Yes, Nidish?
Corpus callosum glioma, sir.
Okay, very nice. So it could be a corpus callosum butterfly glioma. You can see the butterfly shaped lesion here with heterogeneity with perilesional vasogenic edema. It's affecting the corpus callosum extending on both sides of midline. There are DDs, but in a spotter situation, I think you will be good in calling this. It could be a lymphoma too, but उसमें hypertense होना चाहिए था थोड़ा सा. Yeah, Pratibha?
Sir,
You okay?
don't know.
The left ACA territory. In fact.
Acute left ACA territory infarct. There is an area of acute restriction of diffusion in the described vascular territory of the ACA involving both the white and the gray matter. This is acute ACA territory infarct. Yes, Nidish? Something is missing.
Yes, sir.
Corpus callosum.
Corpus callosum.
The corpus callosum is seen.
Azygous is
Temple usage.
Azygous तो हो ही सकता है. What was that again? प्रतिभा क्या बोली?
The septum pellucidum is not seen.
Diagnosis is
Holoprosencephaly.
kind, type.
I
क्या हो गया अगर सिर्फ कॉर्पस कैलोजम एजेनेस मतलब सॉरी कॉर्पस क्या केवल सेप्टम पेलिसुडम एब्सेंट है तो यस निदिश
so lobar.
लोबार holoprosencephaly. Yes, Yogesh? Nidish?
So dissection. So
Left eye.
Left ICA dissection. Nothing is going on. In fact, it should be, why even the PCA is involved, that's a little confusing, but ये हो सकता है कि the left PCA must be a, नहीं, the left PCA must be aortic होने से तो फिर left right का नहीं होगा ना, ये this has to climb into one of the left-sided vessels. Okay, so left ICA dissection is the best bet. Okay, and might be a fetal PCA.
fetal PCA.
Okay, on the left. Okay, you do not see any vessel on the left side. So this happens classically in a left ICA dissection. Yes, Pratibha? Nidish?
Arachnoid
Sir,
cyst.
arachnoid.
Arachnoid cyst in the right posterior horn of the
That-
occipital horn of the right lateral ventricle. Okay, visual DD would be a trapped ventricle, sometimes an intraventricular hydatid, so on and so forth. Can be DDs and if pushed, otherwise it's a arachnoid cyst. Yes, Pratibha?
The neurofibroma involving the left optic nerve.
नितिश ऑप्टिक नर्व में दो चीजें होती हैं क्या क्या
Optic nerve meningioma.
या फिर
Glioma.
ऑप्टिक नर्व ग्लायोमा और ऑप्टिक नर्व मेनिंजियोमा Okay, Pratibha, put up the differences, imaging differences between optic nerve glioma and optic nerve meningioma. Okay. There is difference in the eccentricity, there is difference in the attenuation, the signal intensity changes, the variegation, the kind of contrast enhancement, okay, so on and so forth. So there are some differences. Yes, Nidish? Hmm?
This is also whole experience pathology.
क्या बात कर रहे हैं, कुछ भी ना.
Meningeal, leptomeningeal enhancement, sir.
It's both pachymeningeal and leptomeningeal enhancement. You can see
Meningeal
that.
enhancement.
So at least give meningitis as a possible DD. Okay.
Sir.
But sometimes what you can have leptomeningeal enhancement with subdural collections. ये सब the dural effusions जो होते हैं वो we can have that in क्या बोलते हैं उसको यार IIH में. Okay. But this one is meningitis. Yes, Yogesh? Nidish?
Sir, white cerebellum sign.
In?
Says a diffuse cerebral edema.
Yeah.
Maybe secondary to a severe head trauma or
Whatever. I mean, it's a diffuse cerebral. This thing might have had a cardiac collapse in the emergency, and then they revived the patient and finally could ventilate it, the patient, but remained comatose. And then when the CT was done, that showed this thing. But yeah, gross cerebral edema. Generally, we have a wide cerebellum sign because of the better sympathetic control of the circulation in the posterior circulation. Huh? Yes, Yogesh?
Sir, right side is vestibular schwannoma.
Nidish? This is a typical vector of growth of this lesion.
Trigeminal.
Yeah, this one is going from the prepontine cistern into the Meckel's cave. Okay, so this one is a right-sided fifth nerve schwannoma. Yes, Pratibha, speech bubble.
Sir,
Yogesh?
Baker's.
Baker's, Morant Baker's system, complete now. Yes, Nidish? बोलो. Expansile lytic lesion involving the mandible bilaterally, maybe one of them seems to be क्या हो सकता है?
Osteomyelitis, chronic osteomyelitis.
No, not at all. It doesn't like this. This is an expansile bony lesion involving the mandible.
Fibrous dysplasia.
yes, sir.
This one,
Simple
there is
aneurysmal
ground-
bones.
aneurysmal bone cyst, but what about this then?
OKC.
Hmm?
Odant.
So, this is like a mixture of lesions. I'm not too sure about the diagnosis. I think this should be an ossifying fibroma and this should be an ABC, GCT, or the rest of the expansile bony lesions that we have. I'll come back with the diagnosis, whatever this is. Huh? I'll let you know. Nidesh, this one?
Thyroglossal duct cyst.
Okay, likely infected thyroglossal duct cyst. Huh? Midline cyst in relation to the thyroid cartilage, peripheral enhancement, central non-enhancement. Yes, Yogesh?
Nasopharyngeal carcinoma.
Yogesh, Nidesh? Anyone?
Aqueduct stenosis.
Excellent, very nice. Aqueductal stenosis causing hydrocephalus, dilatation of the lateral ventricles, the third ventricles, and non-dilatation of the fourth ventricle. So the obstruction is here. You can see a web or whatever. What is this? What's this?
Third ventricle.
अबे ये क्या है? ये काला.
Part of the
बिंदी.
thalamus,
Yeah,
intermedia,
the mas-
massa intermedia.
This is the massa intermedia. Interthalamic adhesion. Yeah. Yogesh?
Posterior fossa arachnoid cyst.
Nidesh?
with
So communicating hydrocephalus.
प्रतिभा? इसमें से सिर्फ योगेश को अभी तक मार्क्स मिले हैं. फिर भी.
With posterior fossa
आधा.
arachnoid cyst with obstructive non-communicating hydrocephalus.
क्यों तुम लोगों को वर्निस कहाँ नजर आ रहा है? This is a DWM. Okay, ठीक है. Posterior fossa cystic malformation, DWM, DW variant,
Candy.
Blake spout cyst, large arachnoid cyst, all of that. But when you do not see the vermis in a true midline, this thing, then what? Why are you saying so? The arachnoid cyst होगा.
Can displace the